Good evening, everyone, and welcome to our continuing education webinar called Can There Be Gentle Yet Effective Ways for Slough Removal? What does the evidence and experience say? We are really grateful that you have taken the time to come out to hear our very experienced speakers. And you can see here, we have a representation of clinical excellence, advanced clinical practice, and science and research across our three speakers. And so I'd like to briefly introduce the speakers, and then we're going to get right into the presentation. At the end of all of the presentations, we will be having a facilitated question and answer session. And so what I would like you to do is to put your questions in the Q&A box that you'll see in the bottom of the navigation of your screen. And then we will pull the questions up and make sure that you can address, or our panel can address them. And so I'll just briefly introduce the speakers. The first speaker you can see on the screen here, Dr. Christine Murphy. And Christine is a PhD nurse. She is a advanced clinical nurse specialist at the Ottawa Civic Hospital. And she runs the lower extremity wound clinic. And she has many years of experience and has a lot of experience in the area of wound hygiene. And then we have Karen Laforet, who is based in Southwestern Ontario. And she is not only have her Master's of Clinical Science in Wound Healing, she's also a certified vascular access nurse. And she has a wealth of clinical experience in wound care and also in research and other areas of wound healing. And then we have Vashe Chakravarty, who is a PhD scientist, and he is directing the scientific and research program for Urgo. And so I would now like to turn things over to Vashe, and we'll get right into the presentations.
You're on mute, Devashish.
Thank you so much. A little bit of technological challenges happening here this evening. I'm really honored to have such esteemed company, and we're running a bit late, so I will just jump into the presentation right away. We are going to be discussing products that not only help wound healing, but help with wound bed preparation in unique ways, specifically deals with the necrotic tissue and slough issues on an ongoing and continuous basis. This is a big deal. And so I want to introduce, or I want to welcome Christine Murphy over here to start her presentation. Thank you so much.
Thank you, Devashish. Yes, we have a few little technical issues to start, but thank goodness for technology so we can do this across the country. So welcome, everybody. I'm going to ask for the slide to be advanced, please. Okay, so why are we here? We're talking about this chronic wound dilemma that we all face every day when we look after our patients. You know, this wound that just will not move forward, or is challenging. You sort of go forward a couple of steps and then you're back, and so on. So this chronic wound, anybody that knows me, I don't like the term chronic wound because it sort of says that you're kind of giving up the ghost a bit. A chronic condition is something you live with and you don't necessarily cure. So the terminology is changing now to hard to heal wound, which is a problem that you can tackle if you're given the resources and you take the time and attention to do that. So what is the key barrier to healing in these hard to heal wounds? You know, why are these wounds stuck in the inflammatory phase? I'm sure you've heard this. I would argue they're not stuck on pause in a healthy inflammatory phase. I would argue that this is a dysregulated hyperinflammatory phase. And if you understand that that is the issue, then you have to figure out, okay, well, why are these wounds in this hyperinflammatory phase? What is the reason for this? Because if you can address this hyperinflammation, then you can impact the wound response. You can get these wounds moving ahead. Next slide, please. So in dentistry, actually, we've known this for well over a century, that, you know, this concept of dental hygiene has been something that's been around. We're all very familiar with gingivitis, right? And gingivitis is a biofilm hyperinflammatory condition. So the biofilm acts like a parasite on the tissue, and the body tries to kick it off, right? So you all know when you go to a conference and you forget your toothbrush and you've got that kind of furry stuff on your teeth, and how irritating that is to your gums, and you're just dying to get a toothbrush and to clean out your mouth. What you're feeling is the impact of that parasitic plaque that is on your gums, and you're feeling the hyperinflammation, the tissue response to that, which is uncomfortable. The same thing's really going on in the wound when you get biofilm, which is bacteria's natural state on tissue. The body's trying to kick this parasite off the surface of the wound and trying to flush it out. So in dentistry, we know that plaque is the ever-present threat. We know that we need to do this care for our dental, our oral health on an ongoing basis. And studies have previously shown that in order to manage the plaque biofilm, you've got to physically remove it twice a day. So we all have been taught since we were very little to brush our teeth twice a day, because we know that biofilm just comes back. But, you know, just brushing your teeth with, you know, just rinsing with water, again, you would feel that wasn't enough, right? Because you know that that's not really getting things clean enough. You can feel it. In the wound, it's the same thing. So you would require in your mouth an anti-biofilm cleanser, toothpaste that we all will use, not just rinsing with water. Next slide, please. So, you know, also some mouthwashes may retard biofilm growth, right? You get a longer degree of protection, and sometimes you require like really good cleanings for an optimal health. So we have things called dental hygienists, what people call dental hygienists, that help us really keep that environment in our mouth as clean as possible so that our teeth and gums are healthy. And then, you know, also there's applications, things like fluoride and sealants and so on, that may be beneficial. Again, maintaining this environment as long as you can, because we know that biofilm comes back and it requires constant attention. So how does this parallel when we think about these wounds that are in this hyperinflammatory state with biofilm? Next slide, please. Well, if you compare dentistry with wound care and you think about the cleansing, you know, in dentistry, you'll use a toothpaste, but in wound care, we really do need an anti-biofilm solution. We need to clean that wound and the peri-wound with an anti-biofilm solution, because we know it's there if a wound's been there for any period of time. We know biofilm is the preferred bacterial state, and we know that biofilm grows on open wounds. So we know it's there. We need to have the tools to be able to manage it on an ongoing basis, just like we do with the plaque in our teeth. So we need to use a solution. And this is in the wound and the peri-wound, of course, where bacteria can live. Now, also in physical removal in dentistry, we're used to using toothbrush and flossing and so on. And with wounds, we need to clean with intent. So we can soak and make sure we have that dwell time to have the solution activate as much as we can. But we also want to physically then remove any debris that we can. And then retarding the regrowth, you know, we're used to things, again, like toothpaste and mouthwash. And, you know, in wound care, we use advanced microbial dressings to get us from time to time. And then optimizing the health, you're getting the professional cleansings with the hygienist in dental care. And in wound care, we're looking at debridement, including surgical debridement, to really get that wound bed prep done so that, you know, there's not such a nice environment for that biofilm to grow and be at home. And then, you know, promoting that environment for healing, you know, in dentistry, we have fluoride and sealants and so on. And in wound care, we have the advanced dressings that we are very used to. Next slide, please. So we published recently, I published with Phil Bowler, who is a biofilm scientist, and Dr. Fahad Chowdhury, who's one of our infectious diseases doctors at the Ottawa Hospital. And we suggested that, you know, just like we know about gingivitis in dentistry, that we should term this granulitis in the wound. This makes it much more intuitive for people. These wounds are hyperinflammatory because of this state, this granulitis, this inflamed granulation tissue. So if we think we have granulitis in wounds, and we need to treat it on an ongoing basis, again, with the same 4 steps that we would use in dentistry, then we have a strategy to manage these wounds so that they get an optimal environment, and we can move these wounds out of this chronic or hard to heal state and into an acute wound healing state. Next slide, please. And, you know, the consensus documents all agree that proper cleansing is important, and we need to pay good attention to this. And I invite you to do some reading around to see this. These are some of the consensus documents right here. I'm going to ask the next slide, please. And so what cleansing solution might you use? Well, you've got to think, is it an effective cleansing solution eradicating pathogens, and particularly biofilm that we know is there? So not all cleansing solutions are equal. Is it non-cytotoxic to the healing tissue and the cells that need to move around and reconfigure themselves into a solid matter that fills in the defect? Is it in the right pH range for wound, skin, and bacterial environment? So, you know, the right pH for the cellular structures to sort of, again, reconfigure themselves and the skin to grow in, but also a lower pH, much like the acid mantle that we're used to knowing about on our skin, so that bacterial growth is not encouraged. Is it suitable for use every day? So we've said that we need to keep going at this all of the time in regular dressing changes. And is it improved by dwell time? So this is something to know, right? If something is sitting there for a longer period of time, and if it may be more effective, then you need to follow the instructions to use it properly. Next slide, please. So current guidelines suggest that we need to use topical antimicrobials to reduce bacterial and fungal, let's not forget that, bioburden in these wounds, so that we get to an area, to a level that doesn't impair healing. We want to effectively kill the planktonic and the biofilm bacteria without killing the wound cells. And we know that many of the topical antiseptics that are in use may be cytotoxic and kill these healing cells. So we don't want that. We want to make sure we're using solutions that are optimizing the environment for healing. Next slide, please. So actually, hypochlorous acid is actually something the body generates anyway. When neutrophils go and attack bacteria, this is what, when they surround that bacteria, hypochlorous acid is actually what the body produces to kill the bacteria. So in that way, it's very friendly to the body. It's something the body is used to. It's something the body uses as its own protective mechanism. Next slide, please. And it's effective against various pathogens. So the multi-drug resistant bacteria that we all unfortunately have to deal with on a daily basis, viruses, fungi, and spores. And it's demonstrated to eradicate over 99% of these pathogens in 15 seconds. Now, you do want to keep it on longer than 15 seconds if you want to have, you know, some depth. If you think about the, you know, the slough and so on that's in wounds, we're also helping to sort of remove slough with this, using it in combination with the dressing. So, you know, it will kill pathogens very quickly, but typically we're going to soak this for a bit longer in practice. Next slide, please. And it is known that saline just doesn't disrupt biofilms, right? And they've done studies here. This is one study by Day and colleagues from 2017 who looked at wound biofilms treated with Vashe and chlorhexidine and normal saline. And they found that, of course, Pseudomonas and MRSA, these biofilms had significantly more biomass reduction than normal saline treated biofilms. Now, the chlorhexidine, of course, also reduced biomass, but remember, it's cytotoxic, so that's no good. And, you know, cleansing, Urgoclean recently published a paper, and I invite you to look at this one in the International Wound Journal, looking at non-antiseptic versus antiseptic solutions, and showed that cleaning with the antiseptic properties was more effective than in reducing bacteria than with just things like saline, soap, and water. So you do need the antiseptic component, not just the surfactant. Next slide, please. So according to current guidelines, we want to minimize harm. So we don't want to kill the wound cells. Again, all of these consensus documents agree with this. And many of these topical antiseptics are cytotoxics. Things like hydrogen peroxide, Dakins, chlorhexidine, they're not recommended for use in open wounds because of the risk of tissue damage in their use. So we shouldn't be using these for those types of wounds. Next slide, please. So cytotoxicity matters. But you know, when you take a Vashe solution, it's not cytotoxic. So they tested out in a rabbit's eye, and there was no irritation. Guinea pig, no skin sensitization. Again, dermal irritation in the rabbit. There was no erythema or edema, no irritation. The rat, no oral toxicity. It's non-mutagenic, and it's biocompatible with fibroblasts and keratinocytes. So, I mean, it's a very safe thing to use. And when you compare it with other solutions, as far as cytotoxicity grade, so you can see the hypochlorous acid 4 times the normal percentage of Vashe. So it's actually much stronger. It still got a pass as far as not being cytotoxic. Also did saline, but of course we've said saline is not effective at removing biofilm. But you'll notice all of the other usual suspects that we may see in practice, they all failed the cytotoxicity threshold. Next slide, please. So, and just to finish up my little part in acute care, just a few case studies. So we just move on. So this is a surgical groin, and we've got this unhealthy hypergranulation, so this granulitis, right? So we can tell it's pale. There's a hypergranular presentation there. The skin is lower than the surrounding granulation. This is not going to heal very well. This is an early 60s male. His history of HIV, peripheral vascular disease, hypertension, and critical limb ischemia. And so, of course, he had a bypass with a prosthetic graft and right groin exploration, and they took out a hematoma, and they put a sartorius flap in there, so a muscle flap to protect all the underlying structures. And he had negative pressure therapy, but he ended up with this hypergranulated wound, pale pink granulating, but again, granulitis definitely there. Next slide, please. So what did we do? Well, it's unhealthy granulation, and it required some vigorous attention, and there are various, again, consensus documents you can look into for this. We cleansed with the Vashe solution, and we used some vigorous mechanical cleansing plus 10-minute soaks. We refashioned the edges with curette, and we dressed with an antibiofilm hydrofiber dressing, and you can see that the hypergranulation resolved, and he went on to closure. Next slide, please. We use a fair bit of ultrasound debridement, people that know me, in our clinic, and this is vigorous and intensive approach, and this is one of our residents doing that in our clinic. And so we often will do this in preparation for a surgical closure of what was previously considered a chronic wound. It's hard to heal wound. Give us a challenge, and we're going to close it surgically for you. But of course, you've got to decontaminate this. It's critical for the skin graft take. And whenever we do these ultrasound debridements, we always pre-soak and post-rinse with Vashe solution. Pre-soaking so that we're not sort of inoculating the surface bacteria into the deeper tissue, and the post-rinse to clean up any bacteria we may have woken up during the procedure. Next slide, please. And here's another heel. This is a pretty devastating heel. Most of these types of heel wounds go on to above knee amputation if you look at the literature, but this is a posterior heel, neuroischemic, male, mid-50s, diabetes type 2, peripheral arterial disease. He had a revascularization with angioplasty, hypertension, dyslipidemia. Next slide, please. And we were able to get this closed in time. He had a calcaneal OR debridement, negative pressure wound therapy. Again, he had the Vashe soaks for 10 minutes with every single dressing change. He had the weekly debridements with sharp and or ultrasound debridement, most with ultrasound debridement. And then he went on to skin graft closure at 14 weeks. So, you know, this is pretty, you know, to get something this deep closed in 14 weeks, this is pretty stunning when, you know, most patients like this will go on for above knee amputation. Next slide, please. So when you get decent prep, you get choice. And again, we often skin graft these things closed. This large tibial ulceration would take months and would probably turn into sort of a venous ulceration. So again, Vashe soaks, good prep, And then we get these wounds closed in short order so they can get on with their lives and not get into complications. Next slide, please. And sometimes it's important to recognize that sometimes you can't do everything with just, hygiene to the wound. Sometimes you need to know when you're out of your depth and need more help. Sometimes you need to talk with the team. So this is a groin wound. Obviously, there's purulence everywhere. This is not something you're just going to treat with an antiseptic soak. This is something that needs surgery. So always have your team behind you. Always have a good plan. Know what you're dealing with. Make sure you have a good wound assessment and then have a good wound plan. But cleaning with an appropriate solution is going to give you better results for most wounds. Next slide, please. And I'm going to pass it on to Karen.
Thanks, Chris. Thank you for the detailed overview of why proper wound cleansing is important, why we need to disrupt that biofilm. And so I'm going to shift a little bit because I'm actually quite envious of all the bells and whistles that Chris gets to use. However, we don't have that in the post-acute phase, or place, I should say, care settings. So for those of you that don't know me well, I am currently doing a lot of work in long-term care. And Benoit, if you want to go to the next slide, please. And, working in home care and also in the community and long-term care, we know that cost really does drive product availability. So we sometimes what we would like to have, we don't have because we're forced to compromise. And we all experience that push and pull regarding products and services that are needed to treat the wound. And our reality is, of course, because we have this misperception of cost of a product versus total cost of the care. So I'm going to talk a little bit more about that as we move forward. But what I'm seeing and what has been the mainstay for wound cleansing is, as you can see here, sterile water, sterile saline, and povidone iodine. The scary piece is, like, as I'm going from long-term care to long-term care home, these are the mainstays. And I'm not going to tell you how long I've been a nurse, but it's been quite a while. And this stuff was the mainstay before I even started in nursing school. So we have these, what I call sacred cows, like, thou shalt use this forever because we've always done it this way. But we know that we now have the evidence. There are, as Chris showed, there's consensus documents that are saying we need to do better for our patients so that these wounds will close and we reduce the risk of complications. Added on to the limited availability of products is also the fact that we're working with staff who have limited knowledge and skill. Over and over in the facilities I've been in, the majority of the nurses working in these facilities have less than 3 years experience. And this is in some of these rural hospitals as well. So we're working with nurses who have limited wound care knowledge. They've been taught, again, we have this legacy behavior, this legacy, ways of cleaning wounds that is just not working. Next slide, please. So you're probably wondering why I have Pope Francis here, because I use the term and you're all going to recognize this, because how many of you have seen what I call anointing the wound, right? They take a little bit of saline, little squirt, kind of like bless it, and off they go. That's the Pope Francis model. Or the one up in the top right-hand corner, dampen a gauze, circle around the wound like a few times, and then that's it. And of course, then we also have irrigation under pressure, which is beneficial in loosening debris. However, what I'm seeing is that inconsistency of practice, inconsistency in how wounds are cleansed, and the focus has been on the wound, not the wound edge, not the peri-wound. And so if we can go to the next slide, I believe. Yes. And so Chris alluded to this article that has just been published with regards to looking at cleansing solutions with antiseptic properties were more efficacious in reducing bacteria than non-antiseptic solutions. I'm going to come back to that in a few minutes. The pictures here show something quite fascinating, that most wounds in the saline groups, and you can see the majority of them, demonstrated a positive change in bacteria post-cleansing. So what we're seeing here is that what she found is that the saline and soap had minimal no effect on germ levels, which Chris has already talked about, so we know that. But what's happening is that we're suspecting that the bacteria that's on the peri-wound is being flushed into the wound bed. So we're actually not only not cleansing the wound properly, but we're actually increasing patients' risk of harm because we're reintroducing germs or bacteria into the wound. Next slide. So, we mentioned that there's, whoops, oops, okay, too fast. I had this planned anyway, so it's okay, you can put it back now. So, non-antiseptic versus antiseptic solutions. There is a question actually that's come in the Q&A about, what's the difference? What do you compare one to the other? And in the article, we know that in the study, there is no statistically significant difference between antiseptic cleansers. So then you kind of go, say, what? So what are we going to do? How do we then select the best antiseptic? Now you can go, okay, good. So there are what we call tiebreakers. So what are the three key components that we need to consider when we're looking at choosing an antiseptic cleanser? So next, click away, perfect. So these are the three most important components. Cytotoxicity. Chris has already shown that hypochlorous acid is 0 on the 0 to 3 scale as far as toxicity. I'm seeing in my care settings that they're using povidone iodine because we've always done it that way, and they're using that as an antimicrobial or antiseptic cleanser. And then they wonder why the wounds have taken months and months and months and nothing's happening. Is because povidone iodine is a 3 out of 3 scale, right? It is highly cytotoxic. We also want to look at an antiseptic cleanser that also has debriding mechanisms in it, or components that actually help to lose or loosen the slough that is embedded in the wound. And then, of course, the pH. As a refresh, bacteria love a neutral pH. They thrive in that. They do not like acidic, nor do they like alkalitic pHs. So therefore, having something that is more acidic for a pH is actually bacteriostatic. So these are the three key components that you want to be looking at when selecting the antiseptic. Next slide. And so when we talk about Vashe, as Chris has shared so well, Vashe meets all those three criteria, and it has a wide variety of ways that leads to streamlining and not only standardizing wound care products, as well as compromising skin, but it meets all the criteria that we're looking at. And what I'm finding in my practice is that by adding that to the wound care protocol, irregardless of whether or not I'm changing anything else, it's helping to standardize effective and proper wound cleansing practices. So you can see here that Vashe works on everything, and Chris has already mentioned that. So we'll go to the next slide. And I just want to give a few case studies on how adding Vashe to protocols has actually made a difference. So the next slide, thank you. So this is an elderly woman, had a pressure-related injury. It is a coccyx wound, and it had been in this state for greater than 6 months. So I was called in to do a consult. They were using saline soap gauze packing in the wound for cleansing. They had a variety of different packing materials, and they were currently using methylene blue, gentian violet. You can see here lots of maceration. It's kind of hard. I'm not sure how good your screen is, but right here, this is an actual necrotic patch. There was all kinds of slough up on the very top. There was undermining here that really had a lot of loose slough. So things were not working well. And this is just what looks like really hardened hypergranulation tissue. So I said, you know what? And it was the long-term care home had a lot of agency nurses, and they didn't want to change too much of their protocol because they were really concerned that there wouldn't be consistency. So I added Vashe. I said 5 to 10 minutes soap. So we averaged 5 minutes, and I'll take what I can get. And so if you can show the next slide. So we did the Vashe compress and cleanse, 5 minutes average. We didn't change anything. And in 2 weeks, you can see the difference on how this particular really hardened area had started to soften. The necrotic patch was gone and all the slough was removed here. So just having them use the Vashe compress, going around and just gently wiping, and because didn't have the confidence that they would know how to actually scrub the wound bed properly. So I taught them how to do it very, like go around circular. Nonetheless, you can see that it's making a difference. And in this particular home where there are a lot of older nurses and very new nurses, like, oh, this is silly. 5 minutes, I have to sit here and wait for 5 minutes. Well, when they saw the difference in this wound within 2 weeks, I had some believers. And so we were able to start implementing it, making more changes. So the next slide. So the next case is a wound again that's over 35 weeks. We were using autolytic debridement. That wasn't really doing much. You can see some hypergranulation in here. We were using a wide variety of wound dressings. And so we started the Vashe compress. And in this particular case, we were able to do 10 minutes. And so that's the only thing that we did. And I apologize because I can't remember what the actual primary dressing was that we were using. But nonetheless, what we did was we added Vashe compress. And if you can go to the next slide. Sorry, next click, thank you. So in 28 days, whoops, back one, sorry, Benoit. So you can see here after basically 4 weeks, the difference in the wound bed. We have, slough that's been removed. We have some healthy granulation tissue. We are still trying, and so this made a difference. And so the last slide that I want to show you in the last case is very similar to this. It was a traumatic wound. We had reoccurring eschar that kept coming in. It would go from highly exudative to dry. And so again, we started the Vashe compress. And you can see within 30 days, we're seeing a difference in all of the debris in the wound being removed. So you can see that Vashe does make a difference, just the Vashe compress itself. So the next slide. And so, this international consensus document, another one on wound debridement, Chris had showed this little picture before. It's like a lovely little train there. But anyway, what this document has confirmed and promotes is that hypochlorous acid can be used to assist various standalone debridement methods, as mechanical debridement, selective sharp surgical debridement. At the end of the day, though, we now know, we've demonstrated, and there's lots of evidence that continues to reinforce the fact that Vashe also, if you could just kind of click there, Benoit, that it is a debriding cleanser. So, our talk today is looking at some gentle ways of helping to remove slough and clean up that wound and hopefully move towards closure. And so hypochlorous acid cleanses and it also debrides. So the next slide. So we know, and again, this is a refresh because you all know this. We know that tissue debris is kind of like the Mandarin buffet for bacteria, right? It has lots of fiber, it's got lots of stuff that they can eat, and they just end up, it promotes biofilm, it interferes with new tissue growth. We end up with delayed wound healing and further complications. And so debridement is absolutely essential. Depending upon your care setting, though, we're not all fortunate like Chris, who has ultrasonic debridement methods and surgical debriding and all that good stuff. So in cases like long-term care, something that's gentle and effective like Vashe has really made a difference, at least in my practice. There are other methods, and I'm going to turn it over to Dr. D because he's going to discuss a new and innovative debridement product. You're on mute,
Vashe.
Yes, sorry about that. Can you hear me okay?
Yes.
All right, good. Well, thank you so much. Those are masterful presentations. And you saw that a lot of the cases had necrotic matter, slough, debris, whatever you call it, you actually cannot see biofilm, but you know it's there from all the published research that's out there. And visible removal of necrotic tissue and debris and slough is visible with the use of Vashe. In particular, this is dramatically visible if you use negative pressure wound therapy. Then the necrotic tissue comes out in force, and sometimes it'll clog your tubes. But there is a paper that has been published on how to go around the problem of clogging tubes. Send us an email and we'll send that paper to you. It's available free of charge from the Wounds website. And Dr. Murphy is an author in that Canadian paper, along with Luc Thiot from France and many others from the United States. Now, I want to talk about a new technology. And so next slide, please. This has been there for a while in Europe, and we are just lucky to bring it to North America. We'll be talking about that. It's true that there are many options for debriding. You see them on the slide here. I will not go through them. You know what they are. But people use things in the wound to make necrotic tissue go away when you cannot sharp debride or mechanical debride. And next slide, please. But I think there's a general appetite for a good product that debrides at low cost without pain. People are looking for the holy grail. Uh, and microbial colonies and biofilm, these are associated with wound debris, and we got to get rid of them. When you debride, you get rid of a lot of germs and the homes for germs. So these are guidelines that talk about that. Nothing earth-shatteringly new over here. Next slide, please. So what we do see sometimes is that when you mechanically debride and you go to change the dressing 3 days later, there is slough. Again, where did that come from? Now, current theory, there's a paper that has been published out of the lead researcher is Canadian, actually, fantastic paper, whose title is very simply, What is slough? Slough could be rotted tissue, and rotted tissue can be rotting plasma or blood or rotting solid tissue. Um, and we suspect, at least I suspect, that a lot of the slough that comes into the wound is from rotting liquid tissue that the wound is always giving out, that denatures, and the precipitated proteins go and stick to the wound bed, and that's why you see that yellow stuff when you remove the dressing. And then they got to get rid of it. And then, a new product should be effective, accessible, must be easy and comfortable, and it should prevent that reappearance of slough and therefore enter the new product called Urgoclean Ag. Now, this uses charged fibers, and I'll go into that a little bit more. And in this dressing, 95% of the work is done by the special fibers. The silver is there to a very reasonable and an effective extent to provide an antimicrobial barrier. But you would not adopt this product for the silver. You would adopt it for the debriding power of the fibers. And how does it do this debridement or the support of debridement? Let's talk about that in a little scientific detail. Next slide, please. So I'm a chemist and I got to geek out a little bit, I'm sorry. But biomaterials that are fibers that are used in wound dressings have some physical chemistry effects. Remember, these are devices and they don't do chemistry, but they do physical stuff. They stick to things. And how do things stick to other things? Adhesive chemistry is actually a very involved field. And I could spend 3 hours talking about steric exclusion, hydrophobic interactions, and hydrogen bonds. But guess what? I won't talk about them at all today. Instead, I will talk about one unique property this dressing has that shows with that little magnet at the bottom. That's electrostatic interaction. And the electrostatic interaction is the completely understandable and the almost irrevocable and strong attraction between positive and negative charges, almost like between the north and south pole of magnets. That's why, for marketing purposes, I guess my friend Benoit put that magnet over there. So, electrostatic interactions. Let's talk about this some more. Next slide. Next slide. Okay, so sorry. This is a chemical structure of the fibers. The fibers are polymers. They're long chains of what are known as polysaccharides, which are basically glucose-like molecules strung together. Cotton is made of polysaccharides. Your carboxymethyl cellulose type products are made of polysaccharide. Alginates are made of polysaccharide. And some of the popular wound dressings like alginates or CMC-based dressings, they do have negative charges on them. So it's not true that Urgoclean is the only negatively charged dressing in the world. No, there are other negatively charged dressings. But the negative charges that you see here that I've circled, they're rather far from each other. If you count the number of atoms between the two negative charges, they're not next to each other. They're 6, 7, 8 atoms away from each other. So let's say the negative charge is pretty dilute in these dressings. Compare that to the new dressing called Urgoclean Ag. Next slide, please. Where in this molecule, the negative charges are packed tight like sardines inside the dressing. So it is highly concentrated, the negative charge. And this is a negative charge as wound pH, just to be clear. Okay. Now, what does this negative charge do when you put it into the wound? Next slide, please. We can see it in this little experiment, which our clever scientists did in the lab. At the bottom is fibrin, which is the predominant component of slough. Fibrin comes from fibrinogen in plasma, which denatures when the wound is not so good, it'll denature to fibrin and it'll go and stick to the wound. That's a lot of the yellow stuff that you see. Then it's stuck like peanut butter to blanket. It won't come out. Now, when you put a CMC dressing on top of it and then pull up the dressing, the gel remains in the petri dish. It doesn't come out. Same with the alginate. Okay, it doesn't come out. But with this Urgoclean, if you stick it to the fibrin gel and pick up the dressing, the gel remains stuck to the dressing and the petri dish is cleansed. This is kind of sort of an interesting experiment to show what you can expect to see in the wound when you put the Urgoclean Ag dressing on slough that is rich in fibrin. Okay, next slide. So a little bit of chemistry again. Again, hypochlorous. I see a lot of questions about products that contain hypochlorite. Hypochlorite is the molecule present in bleach. And bleach also is that same molecule is used in Dakin solution. It's highly cytotoxic. And then you can dilute it and reduce its cytotoxicity. But remember, when you dilute it, you also reduce its antimicrobial power. So the bleach-like molecules are at a high pH on the right side of this diagram, and then Vashe and the hypochlorous acid is stabilized at high concentration, and that is evidence-based. That is at a pH of 4 to 6. Tons of published literature to show that that pH is what is conducive to healing. Any lower than that is not very good for wound healing. Your stomach acid is pH of 1. You don't want that kind of acidity in your wound, that's for sure. But pH 4 to 6 is the sweet zone of wound healing. And any cleanser that exists in that space and is non-cytotoxic, according to the current standards of cytotoxicity, are really what are recommended by clinicians, definitely by us. Next slide, please. So this is kind of a complicated slide, but I'll explain it very simply. Basically, hypochlorite, which is bleach-like molecule, or the molecule present in bleach, and hypochlorous, they are two different chemicals. They sound similar, but they're different. They're like Dr. Jekyll and Mr. Hyde. Okay, the hypochlorous agent is quite non-cytotoxic, and really that's what our macrophages make. The hypochlorite agent that is present in some commercial products and definitely in Dakin solution, high pH is not conducive for healing, is different than hypochlorous. Yet one converts to the other depending on the pH of the solution. So it goes without saying that we are absolutely nitpicky about the pH of the solution we put in the blue bottle called Vashe. It has got to be in that sweet zone. Next slide. And you see that sweet zone. And that is what we call pure hypochlorous acid or PHA. Okay. And that is where intact skin, acute wounds lie, that pH. And the chronic wounds you can see are in a high pH range. You turn the clock back on chronic wounds by taking the pH into the acidic area. Got to keep that in mind. Okay, so check the pH of your cleanser. Now let's talk about this dressing a little bit. Why did I bring up Vashe while I was talking about Urgoclean Ag? There's a relationship. So this is a cute drawing, but it's an easy one to understand. I'll explain it to you. That pH line, that blue line, imagine that is the wound surface, okay? And the wound can exist between a pH of 4 to 9, okay? I told you 9 is chronic, 4 is nice and healing. The Urgoclean Ag that's on top of the wound, that's why it's on top of the drawing, is always negative. And that is shown with the negative ovals, okay? Negative charges. The slough at the bottom can be negatively or positively charged. You see that slough drawing I put there, that's some kind of pressure injury, I think. That is a negatively charged slough. That negatively charged slough is likely not going to attract the negatively charged dressing all that well. Okay. So, so what do you do to make slough positive? Next slide. You bring hypochlorous acid in. Not only does it mechanically help break down slough, and that's why all that scrubbing and so on things that were happening, it also turns the slough positive, and this makes it very attractive to the dressing. This is how this works. Okay, next slide. So what's the recommendation? Use the hypochlorous acid, mechanically break down the slough a little bit, then add the Urgoclean Ag dressing and let it pick up the slough that you have just disturbed. Okay, so there's RCT, and we won't go into a boring RCT for you to show that the fibers really improve upon hydrofiber type dressing more than 50%. This is published in Journal of Wound Care, so you can look it up on the ability of the fiber to debride or to remove slough. Okay, next slide. And so this is a real life study, huge study. I think this is the biggest silver study out there, 2,270 patients. And this is observational, not randomized, all patients, all comorbidities, and you see a big difference in the sloughing compared to the baseline. Next slide. Okay, so then, therefore, the new debridement consensus paper, that's a publicly available document. Email us, we'll get it to you. It talks about the negatively charged fibers in the context of removal of slough and necrotic tissue. And see the green line at the bottom, slough can be protonated or given a positive charge with the application of a mildly acidic cleanser, such as hypochlorous acid. You can use other mildly acidic cleansers to make it acidic, but again, remember, cytotoxicity matters. Choose your cleanser carefully. Okay, next slide. What about biofilm? Next slide. This product has a huge published study. Well, it's not, it's a very nice study that shows, you see the big arrow drop in the product, in the silver, that's 4 logs of biofilm drop on the use. And again, the same negatively charged thing applies. Okay. So Urgoclean Ag has a negative charge, negative charge. So I see a question coming in. Slough can be turned positive. Urgoclean Ag is not positive. It's negatively charged, the fibers. Okay. Next slide, please. Okay, and here's some clinical cases. These are pressure injuries, and I think we are running out of time. I need to give some time for Q&A. So I won't describe the wounds. Let your eyes tell you what the dressing is doing. You see that unstageable slough over there with a little bit of mechanical help and Vashe soak and the dressing application, it comes out and it does so quite fast. Okay. And you will see a very messy dressing, that I can guarantee you. It'll be gross and it'll be repulsive because it is removing, uh, dislodging the necrotic tissue that is present. Do the next one. And again, this particular one is also quite dramatic. This is on the same patient, actually. You see the same thing. within a matter of 12 days, you have discharge of the patient from this inpatient situation. This patient is in the hospital for 3 or 4 pressure injuries on the same patient. Let's go. Next slide. So I'm going to stop and yield the floor to questions. I see questions have come in. Now, Kathy, are people
Yeah,
going to ask questions live via
yes.
voice?
So we're going to moderate the questions, and I've been collecting them as the presentations have been going through. And first of all, I wanted to say thank you to all 3 of our presenters. Chris, you gave some really great information on non-antiseptic versus antiseptic solutions and applied them to very relevant case studies that were very impactful for vascular nursing. And Karen, you did a fantastic overview of the inconsistency in how wounds are cleansed. And I love the Pope Francis model of wound cleansing. That was really interesting. And Debashish, you gave an excellent overview of the science and how the science is really the foundation of wound cleansing. So that was very, very well done across the board. So I'm going to start the questions. The first one, perhaps we'll start with Debashish and then move to Chris and then Karen. So the first question is, how does combining Vashe and Urgoclean Ag enhance debridement outcomes compared to using each product separately?
That's a great question. Thank you. Can you hear me?
Yes.
Okay. So the one thing I forgot to tell you is that both products, they do things to the wound. Do not mix them. Do not pour one into the other. But you can use Vashe normally, which is apply it, soak it. That helps break up the biofilm mechanically, and then remove it. Pat the wound dry. Within seconds, the hypochlorous acid molecule is extremely labile. It it does veni vici, comes, sees, conquers, goes away. Then you can apply the dry Urgoclean Ag. Urgoclean Ag must be dry to benefit from the capillarity. So, great question. By itself, Vashe will debride. It's on the label. And it does so with a little bit of mechanical help and dramatically so with negative pressure wound therapy. In Europe, Vashe, unfortunately, is not available yet. So people use Urgoclean AG by itself, and they see very good results. I just showed you a randomized control trial. No Vashe was used in that trial, yet we see good results. So the results are good to start with, because the electrostatic force likely also happens when the wound is chronic. If you take a look at the amino acid, PK values, and so on and so forth, I won't get into that. But you can amplify that activity a lot by using Vashe. You turbocharge the Urgoclean AG activity by pre-soaking the wound with Vashe and turning the wound slough deliberately positive. So you get, our chemists are clever, and they've been able to create this synergy, and making sure that one doesn't mix with the other in the wound, taking advantage of the hypochlorous acid's ability to vanish very quickly once it has done its job. Hopefully that answers the question. Thank you.
Okay, thank you. And Chris, do you have any comments on that?
So I would just say, as we all look after these wounds and dealing with the slough in the wound bed prep, it's so critically important. We sit and we fight these wounds for so long, and to use these types of technologies now to reset the wound environment. I think that's so very important. Now, I did notice somebody talking about limiting to 2 weeks, and I think that's sort of a question that I've kind of seen people talking in the chat about. I have no experience with home care, but it doesn't make sense to me necessarily that you would stop addressing the biofilm after 2 weeks. You might get somebody better under control in 2 weeks, so maybe you can turn them around, but remember, biofilm keeps growing, right? And the slough keeps being produced. So it really should be a clinical assessment, I would say.
I'm wondering if it has to do with the community care limiting the product, because I know I'm getting that pushback in long-term care as well. Because yeah, it just doesn't make any sense why somebody came up with a 2-week time limit.
Yeah. So you're saying that Vashe then can be used beyond a 2-week period effectively. In fact, it could be more effective if there is continued use.
I think from the clinicians, of course, they do things using their own judgment. Now, I do have to say that, like all silver dressings, the regulatory limit on use is 28 days. Beyond that, it is always at clinician discretion. That's true for most silver, probably all silver dressings. The other thing is the Vash. As far as I know, Vash can be used as long as the wound is open for cleansing. There is no limit in days as such. Uh, I believe that to be the case.
Mhm.
Right, and we do see in the chat that that they're typically seeing in home care that after a 2-week period the product is reassessed. But we do know based on this presentation that it can be used beyond that. Also, there is a comment that there could be a cost implication. So that is something, again, you have to weigh out the healing time and weigh everything out, but it can be used beyond 2 weeks. Okay.
I think, the cost implication is an important one. For sure, Vash is more expensive than saline. It's a pain in the butt product to make, and it is more expensive than saline. However, I have to tell you, if you read the paper by Dr. Oropallo, you would seriously worry about using saline. You really would. Somebody asked me, what would you use in this chain? What would you use if you didn't have Vash? I used to say saline, Now I'm beginning to worry because her paper shows that you generally, in cleansing the wound, peri-wound germs that were lying nicely on the peri-wound and not harming anything are now healthfully deposited into the wound without getting rid of them. How that's very bad. 62% of the wounds after 20 minutes of cleansing with saline ended up with higher bacterial count in the middle of the wound. Where did they come from? She suggests it probably came from the peri wound, and I believe she's right. And you need to worry about that.
Okay, so I'm going to put this question back to first Karen and then Chris, and then get Vashe to comment. If a wound is stalled, should we use a pro-inflammatory to help move it back into the healing trajectory?
Pro-inflammatory.
Yeah, are we talking about a I'm making the working assumption that that's like a pro-inflammatory dressing, like silver or something like that.
Silver is not pro-inflammatory.
No,
Silver.
it's not, or even better, or even povidone iodine, which is supposedly pro-inflammatory. I think you have to go back and look at the wound, like what's going on and why is it stalled?
Anti-inflammatory is what is generally recommended, to the best of my knowledge, because your MMPs are highly inflammatory, highly, and so you bring down the inflammation, and there is some evidence that silver brings down inflammation. Although and then that's Acticoat folks making Acticoat did a lot of publications in that area. Also, folks doing Promogran and Prisma, the ORC product, they are anti-inflammatory, and so pro-inflammatory. There is some, if a wound never got inflamed. Inflammation has a role, as you know, in the first phase of wound healing.
Yes.
But I've not heard pro-inflammatory. Chris, have you?
No, I would say it was anti-inflammatory because certainly if you've got a wound that is stalled, then most likely you've got that biofilm, and the body is in a hyper-inflamed state trying to get that biofilm off like a parasite. So you're dealing with a hyper inflammation and elevated MMPs typically when you have a stalled wound. So again, you need to come back to dealing with the biofilm. So most of the strategies to deal with biofilm, I would say on removal of the biofilm, are anti-inflammatory strategies.
But there is, I was just thinking, when you debride a wound sharply, you start with an acute phase with bleeding and inflammation, I'm sure, a brief period.
Yeah,
Maybe
absolutely.
the,
Absolutely. But you're
the
resetting the hyperinflamed wound back to an acute
Yes.
healing state. So again, yeah,
It's now,
and it's not a product that you're using to make it pro-inflammatory. So maybe in a diabetic who is not mounting a good inflammation response, you might be using something, an iodazorb or something like that. But maybe that's what they're getting at. But typically, when you're dealing with biofilm and wounds that are stuck, wounds that are just not moving forward, you're looking to reduce the issue, reduce the biofilm, and get back to a normal wound state.
There's
Okay.
also there's a legacy thinking around certain silvers were pro-inflammatory. Do you remember this, Chris? There was some debate a few years ago about some silvers were pro-inflammatory. I'm not saying it's correct. I'm just saying that, there's all this kind of very interesting discussion that happens for people's opinions, where some dressings were considered pro-inflammatory versus anti-inflammatory. There was no evidence, it was opinion, and so it kind of makes people confused. So anyway, I think that could be also part of it.
Yeah, maybe so.
Okay. The next question.
Go ahead.
Oh, the next question, I'm going to start this with Chris, then Karen, and then Vashe can give his opinion. But it's, how does the use of Vashe prior to applying Urgoclean Ag impact the speed and effectiveness of slough removal?
So it activates the slough, as Vashe was explaining. It activates it and makes it ready to sort of couple with the dressing for that magnetic effect, for a very short description.
Couldn't have said it better myself.
Okay. And
Yeah, basically, if you invested in a Urgoclean AG, you can goose up its activity by pre-cleansing with you're going to use a cleanser anyways, and you don't want to be using saline. We recommend you use Vashe. There are many other commercial cleansers, and some people are happy with what they use. They should continue to use them. I would watch the pH of the wound, though, irrespective of the brand you use. Something to keep in mind.
Okay. There is a comment here. Thank you for the chemistry. We currently use Vashe in our clinic, and the result has been very positive. So that was very positive feedback.
Excellent.
Clinically, have you had any issues with Urgoclean Ag sticking to the wound?
Surprisingly, no, so far. I mean, Karen and Chris, this is a new product for us in the USA, and we always heard it was very comfortable. But, we haven't seen that.
If anything, it's because it's so soppy, it's going to be like, how would it stick? So and I'm just thinking out loud, if it was sticking, it would mean that it was dry. So otherwise, I'm not sure why it would stick. If anything, like you said,
I mean, if it wasn't covered with an occlusive bandage, it could stick like this. But generally, it's always covered with something occlusive. What is used as secondary? Sometimes gauze is used, Anytime you put layers of stuff on it, it prevents water evaporation. My other question is, how often do you change? Listen, slough is better out than in. So you want to change it when the slough load is high. It's good for up to 7 days. But if you have slough, why would you want to keep that slough on the dressing for 7 days? Makes no sense. You want to remove it the next day or the second day. And then as slough level goes down, you can reduce your frequency. But I'll tell you where this dressing has given us some issues, to be honest. It is messy. And, slough is messy. And when there's a lot of slough, it may adhere to the front of the dressing and prevent fluid to go through. So if you expect a lot of exudation, it may be worth your while to fenestrate it. Have you guys fenestrated, Karen and Christine?
No.
You have. Do you always fenestrate it or sometimes?
Yeah, I always
Okay.
would do that. Yeah, just because why not?
Right.
It's just easier for the exudate to go through.
Are there any contraindications in using Urgoclean Ag?
Yeah, there is, allergy to silver. We haven't seen, and this is still a new product. We haven't had any adverse events reported yet. I'm sure we will sooner or later. But we haven't seen, we haven't. We get reports, when anything happens nationally in North America. But now I want to ask, and it's a loaded question. I don't know the answer. Christine or Karen, have you seen any negative, any kind of patient complaints or whatever?
No.
Too few
Nope.
to make a point. Yeah, too few
Okay.
so far. Yeah, but nothing.
Okay. Yeah, if you do, let us know because we'll learn
Mhm.
something, So
Yeah.
Yeah.
Like I haven't seen, I haven't seen any negativity or any contraindications or any reactions to Vashe since we've been using it.
yeah, Vash has
Mhm.
been
Yeah.
rarely, if ever.
Mhm.
Um, okay.
Right. And there is a question here about Urgoclean Ag, and will it be available through OHH?
Ontario Home Health.
Mhm.
You don't want your chemist to answer that for sure. So
Yeah, that
Benoit
will.
probably can say that. Benoit, can you comment?
It's ongoing, not yet.
No.
Okay.
May I
And
pick up one question that I see?
yes.
Okay. Does it have to be Bash and Urgoclean AG to get best results, or Bash can be combined with other silver dressings? No, it doesn't have to be Bash and Urgoclean AG. We'd love it if it was, but if you cannot get it or it's not in your formulary, use any other silver dressing with Bash with confidence, keeping in mind. In fact, some of the foam dressings will say that don't put this type of product, hypochlorous or hypochlorite, on the foam, simply because they destroy the foam. You want it to help the wound, not destroy the foam. Never pour Vash into anything but sterile gauze to soak. And then, after soaking, within seconds, as soon as you patted it dry, you can put your dressing of choice, whether it is Urgoclean AG or some other product with silver, with gentian violet, with enzymes, whatever you want, you can put on there.
And that's a
Okay.
really good point, just to reinforce that about the drying. So making sure, because I've seen people put it on wet, put like another dressing on top of, so they take the Vashe, they do their compress, they don't clean, dry the skin or whatever, they just put the dressing on and then they go, oh, what's reacting to it? I'm like, oh, okay, yeah. Especially
Right.
methylene, whatever, gentian violet,
Yeah.
methylene blue.
Yeah.
Yeah, especially that one. Mhm.
And so, based on your experience, and this is for Chris and Karen, based on your experience in working in, I know Karen, you've been working in long-term care, and Chris has been working in the lower extremity wound clinic. How can clinicians best educate their team on the benefits of using Vash and Urgoclean AG for debridement?
I
What's your
think it's, yeah, I think it's experience when you start using it and showing people the results and how things, I mean, we've had amazing results with just using a proper cleanser rather than saline. And I noticed that somebody asked, should you rinse with saline after? And I would say no, because part of what Vash does is it drops the pH to a level that is not friendly to bacteria. So that's part of what it's doing. So if you rinse with saline, you're going to lose the benefit of doing that. So I wouldn't do that. But we've had fantastic results. And as Debaji says, within seconds, it's gone. It's not going to interact with your next dressing. There's no need to rinse it away.
Okay. And Karen, anything that you've seen in long-term care that would bring some experience?
Well, like that case study that I mentioned, the first one where, as soon as I said that they had to try to soak it for 10 minutes, you can just imagine the pushback that I received. And so it was the director of care said, we're going to try this. We're going to try for 2 weeks and we have to be committed. This poor woman is, suffering. But when they started, sometimes, the actual experience, like Chris was saying, like as they use it and they see the benefits. So after that, especially in that one facility, it just took that one case. And then I get like, well, we need some more Vashe. How can we order Vashe? What are we going to, like this kind of thing. And so, yeah. So
And
it's like seeing is believing, right?
Yeah, I'll often tell patients, nurses, put the soak on while you're getting your dressing stuff organized, like get that going first and just let it sit there. And patients, if they think their nurse is in too much of a rush and they're able to put the soak on while the nurse is coming, you're not like leaving it on a bit longer is not going to be a problem. So get the soak on because you do need, the better the soak, the better the clean you're going to get.
Yeah.
Okay. Any last?
Kathy, one question. I'm noticing a lot of questions on the chat box, and I'm just posting my email over there so people can send me the questions, and I'll share it with Christine and Karen.
Okay.
I think we should have clarified, a question and answer session also has a lot of questions, and we have taken pains to answer the appropriate ones. And but there are great questions on the chat side. Can those be preserved and
Oh, yeah.
sent to us?
Mhm.
Okay. If you
Yeah.
could preserve the email addresses of whoever sent those questions on the chat side, they're great questions. It's just not possible to answer all of them.
Right.
I want to be able to do that and respect everybody. I want to thank everybody.
Yeah, and we've almost gotten through most of them. Like, some people or someone asked if they could have your presentation slides, but they may be copyrighted to you.
Yeah, they are. And email us and we will see what we can do because we create special decks for special occasions and stuff. So.
Right. And you do get a certificate of attendance for attending this session. You do have to go online to access it, and that information was in the information email that you got back when you registered. So if you have any problems getting that, you can email office@nswak.ca, but you will get a certificate of attendance. So if we could just have last comment from you, Chris, to start.
I would just say, like, you guys are doing the important work out there. You're informing the nurses that work with you, and your knowledge is so important. And addressing the cause of why these wounds stall is key. And knowing, what we know now about biofilms, you have to consider biofilm-based wound care as part of your critical toolkit.
And to add to that.
And
As I mentioned just think about Pope Francis, we need to get people to stop doing this like legacy behavior. We need to make sure that when we are cleansing the wound, we're cleansing the entire area that impacts that wound, that we don't want to just give it a little blessing. We have to really get in there. That debris, make sure we also clean the peri wound, because that also we have to always remember we have to prepare and protect.
Right. And Debashish.
Yes, thank you, everybody. What a fantastic pair of speakers we have here today. I would say that it's been my personal dream, anyways, to try and impact this much-needed world of debridement, the Holy Grail. Now, I'm not saying Urgoclean Ag is the Holy Grail, but it's an important step in reaching that perfect product that removes slough without pain, effectively and in an affordable way, an evidence-based way. We believe as scientists, some progress here, and we are just proud to share the results of this scientific effort with you all. Thank you so much.
Okay, and thank you very much to our speakers, to Chris, to Karen, and to Vashe. And also thank you to Urgo and Benoit for supporting this education this evening. It's been very interesting, a lot of excellent information. We will have a video that will be available on our website as well that you'll be able to go back and look at after. So thank you very much, and I wish everybody a very pleasant evening.